Well, hello, everybody. I'd like to welcome you to the Data Collection webinar series organized by the Data Collection Unit here in UNICEF headquarters. Just a reminder that this series covers topics that have recently gained prominence or relevance and where there's ongoing work on how best to collect data. Today's topic is data collection of blood samples for anemia and the latest developments. Just a few housekeeping rules before we get started. We have scheduled about an hour and a half today, including Q&A. As always, please keep your mics muted and kindly write your questions in the chat box, and we'll group them together and answer them at the Q&A session at the end. This webinar is being recorded and will be available on our SharePoint site, together with past webinars. We will also post recordings on the Mixed YouTube channel, which are publicly available for everyone. You can find the links to both of these in the email that you were sent. As I mentioned earlier, just to recap that today's webinar is entitled Data Collection Blood Samples for Anemia, Latest Developments. I'm now going to turn it over to my colleague Chika, who is the Senior Advisor, Monitoring Statistics, Chief, the Nutrition Data Unit in the Data and Analytics section in UNICEF headquarters. Chika, over to you.
Thank you, Archana. So as most of you probably know, anemia in women of reproductive age is one of the 6 global nutrition targets. And it's also one of the newest SDGs added in 2019. And so today's topic is on data collection issues related to the measurement of hemoglobin concentration and anemia. Just wanted to let you know that UNICEF and WHO have a global advisory group called TEAM, which stands for the Technical and Expert Advisory Group on Nutrition Monitoring. And the team addresses priority topics in nutrition monitoring through working groups. And today you'll be hearing from some of our distinguished advisors of the Team Anemia Working Group. So I'll give a quick overview of the flow for today's webinar. First, we'll start with an overview presentation by Leila Larson, who is an assistant professor in the Department of Health Promotion, Education, and Behavior of the Arnold School of Public Health in South Carolina. And she carries research on this topic, but also on other nutrition and child development issues. And we appreciate her expertise in joining this webinar. Next, our team advisor, Omar Dary, who is also the Senior Nutrition Advisor of the Bureau of Global Health at USAID, will walk us through some of the key research to date and demonstrate the data collection issues and implications. And we're very fortunate to have him share his knowledge with us. And he's been a very active advocate to make sure we are addressing this issue as a global community. Then another team advisor, Sorrel Namaste, who is the Senior Nutrition Technical Advisor at DHS for Demographic Health Surveys, will share results from a pilot study in a large-scale survey and discuss the findings with us. We're grateful for her implementation experience, and she incidentally chairs our team and optometry working group as well. Finally, Sara Wuehler, our team advisor, who chairs the Team Anemia Working Group and is Senior Technical Advisor for Nutrition Information Systems at Nutrition International in Canada, will update you on the next steps of this working group. Robert Johnson, our newest member of the DNA nutrition team in headquarters, will facilitate the question and answers. So we hope you enjoy the webinar, and without further ado, I would like to hand over to Leila Larson. Over to you, Leila. Get the slides up.
Great, thank you. Thank you for that introduction. And I'll wait for the slides to come up. Can everybody hear me okay?
Yes, we can hear you well.
Okay, great. Okay, all right, so I was tasked with giving a bit of an introduction to the measurement of hemoglobin and the diagnosis of anemia. So I wanted to start off by just saying that we know that the global prevalence of anemia is high. So these data shown here on the maps are from the WHO Global Health Observatory. And you can see that it's estimated that the global prevalence of anemia in 2019 in women of reproductive age, so 15 to 49 years, was almost 30%. And in children, so the map on the left is women, the map on the right is children under 5 years of age, was almost 40%. And you can see from the legend that the dark red countries are those with the highest prevalence of anemia. So severe prevalence of anemia of over 40%. Next slide, please. Okay, so there are many reasons that we strive for accurate measurement. Here are just a few that I think are most relevant for the measurement of hemoglobin and the diagnosis of anemia. So first is to track the progress on targets. So targets such as Sustainable Development Goals that Chika mentioned earlier and World Health Assembly targets. The other would be to better plan for interventions and programs. So if we know where anemia is of most concern, targeted approaches can be used for different settings for different populations. The third is to evaluate the effectiveness of interventions. Accurate and precise measurement of biomarkers such as hemoglobin is necessary to evaluate impacts of interventions and programs. And lastly, to advocate for resources and for investments. Next. There are many ways that hemoglobin is measured. First, there's the option of what blood source is to be used. So one can use venous or capillary blood. Venous is usually from a peripheral vein in the mid-arm. Capillary is usually from a finger, but it can also be from a heel or an earlobe. When using capillary blood, it's typical to wipe away the first and the second drop and then use the third drop as the source for the hemoglobin measurement. And the other option is to not use just a single drop of capillary blood, but instead to use a pooled sample from multiple drops. Next. So there's also various analytic methods available. The most common method for hemoglobin measurement are automated hematology analyzers. These are analyzers such as Abbott Celldyne, like the one in the picture on the top here. Sysmex, Beckman Coulter are other well-known ones. And portable hemoglobinometers, such as the HemaQ, which is pictured on the bottom of the slide here. And that's really the most common one used. Next. So let's go over some just key characteristics of the different blood sources. We've already talked about the location of the sample. Venous samples would require a phlebotomist, whereas capillary samples, so single drop or pooled, can use any person that has been sufficiently and received standardized training. Venous samples can measure more than just hemoglobin. So with that sample, they can be used to measure different analytes, complete blood count, other micronutrients such as ferritin, and also malaria. Capillary drop can be used mostly to measure hemoglobin. If there's enough, it can also be used to measure malaria. And for pooled samples, this is usually enough to measure other analytes besides hemoglobin. Some advantages of the venous sample are that it's a larger blood yield, so can measure other analytes. For capillary samples, the advantages include that it's a simple process once the staff are trained. There are some disadvantages to both those. So for venous samples, it requires a trained professional, so a phlebotomist. Some disadvantages of the capillary single drop are that it's a very small yield of blood, so limited analytes are possible. And it has shown very wide variability in hemoglobin estimates, so very high imprecision in the measurements of hemoglobin. For capillary pooled, it's also a smaller blood yield than venous, so limited analytes here, and there's limited data available to assess the precision of measurements. But Dr. Dary will be presenting more on this in the subsequent presentation. Next slide, please. So I don't know if it's just delayed for me or, okay, there we go. Thank you. So now here's some quick information just regarding the analytic method. So I'll leave you to read the first two rows. Some advantages of automated hematology analyzers are that it's an efficient and high throughput automated device. It can measure other analytes in addition to hemoglobin. Some advantages of the portable hemoglobinometer are that it's low cost. It's battery operated, so it can be used anywhere. Excuse me, it doesn't need any electricity. It's easy to use once the staff are trained, and it provides immediate results. So it gives you those results in real time. Some disadvantages of the automated hematology analyzer are that it requires electricity, space, regular maintenance by trained technicians. It's higher cost than the portable hemoglobinometers. So just as like a quick comparison, the cost of a HemaQ might be around $1,000. You need cuvettes and lancets for each measurement, whereas a hematology analyzer can be, a typical price range would be between $5,000 to $10,000 US. Some disadvantages of the automated hematology analyzers also include that it requires anticoagulated blood and that there's a need to maintain the blood temperature during transportation. Some disadvantages of the portable hemoglobinometer include that the devices may be affected by certain external factors, especially things like humidity, and real-time calibration is not possible. Next slide, please. So based on evidence, we know that there are inherent differences in hemoglobin estimates based on blood source, like we've talked about, the analytical method, environmental factors like settings of high humidity or altitude, and other external factors like hydration status of the person being measured, their position during blood collection, so whether they're standing or whether they're seated, as well as sample loading time. Next slide, please. So all of this matters for the measurement of hemoglobin and the diagnosis of anemia. So I've created here kind of a hypothetical scenario based on literature, though, that shows how much systematic error can be introduced by a variety of different sources. But I'll just say here the caveat that it is very difficult to disentangle contributions from different sources of error. But as a hypothetical, the device can introduce up to 4 grams per liter bias in the measurement of hemoglobin. And this is from a paper by myself and colleagues that was published a couple of years ago. We've also found that blood source, so capillary versus venous, can introduce a bias of up to 9 grams per liter in non-pregnant women and up to 6 grams per liter in children. It's been found that humidity, this is from a HemaQ 201+, but it can be also other devices, can introduce a bias of up to 5 grams per liter. Fasting versus non-fasting blood can introduce a bias of up to 13 grams per liter. And human error, this is just from my own unpublished data, can introduce bias of up to 3 grams per liter. So you can imagine when you're looking at all of these different sources of error, it's introducing quite a bit of bias in the measurement of your hemoglobin. Next slide. So there really are 2 common types of error that I wanted to bring to everybody's attention when it comes to hemoglobin measurement. So random error and systematic error. And it helps to visualize these using Bland-Altman plots. Bland-Altman plots are here on the bottom, but basically these plots show the difference in hemoglobin measured using instrument A versus instrument B. That's on the y-axis, so that difference is on the y-axis. Across different average hemoglobin concentrations on the x-axis. So random error here is shown by the spread of the data points, so the individual measures. It depends not only on the intrinsic variability of the method, but also on the heterogeneity of the analyte in the specimen, as well as the skills of the technician. Random error can be used as an estimation of the precision of the method. And high random error is very dangerous, and it basically renders the data as inaccurate. The other type of error is systematic error. And this is mostly associated with the intrinsic analytical performance of the method, and it's constant. So the average difference between 2 methods is the bias of the method in use. And it's shown here in these figures by basically the horizontal purple dotted line. So as an example of systematic bias is when a hemoglobinometer like a HemoQ device is consistently measuring hemoglobin slightly higher or slightly lower than the gold standard comparison, which would typically be an automated hemoglobin analyzer. And this is an estimation of the accuracy of the method. So if there's little to no bias, the horizontal line, the dotted horizontal line, would be close to 0. So on the far left, the figure on the far left, we see an example of low random error, low systematic error. So not a huge spread in the measures, in the data points, and the average bias is close to 0. In the middle, we show an example of high random error, but low systematic error. So a big spread in the data points, but on average, a low bias. So the horizontal line is close to 0. And on the far right, this is an example of high systematic error, leading to a bias of -2. Next slide, please. And I just wanted to end my set of slides with a quick reminder that the etiologies of anemia are diverse and vary by age, they vary by sex and by setting. So when designing anemia reduction strategies, it is important to understand its etiology to be able to design effective solutions. So key points, if you're going to take away anything from this talk, remember that the prevalence of anemia is high in women and children. The accurate and precise measurement of anemia in population level surveys can be challenging. So we're seeing from several studies now that single drop capillary samples, which is the method that's most used in population level surveys, including demographic and health surveys, these give biased and imprecise values for hemoglobin concentration. Lastly, the etiologies of anemia are diverse. So approximately 50% of anemia is due to iron, and etiologies vary by age, sex, and geography, but their measurement can be difficult in population level surveys. And I've just included an extra slide. So next, with some key references if anybody's interested in following up on some of the information that I presented today. Thank you very much.
Thank you so much. Over to you, Omar. Thank you.
No, thank you. Can we go to the first slide, please? This presentation is not regarding prevalence of anemia. I'm going to talk about the characteristics of the method. It's something that we need to learn before trying to use these methods in the field. It's for any type of method. We started this work I'm going to present to you today several years ago. In 2019, we have a technical working group to design a protocol, but really our efforts came before that. And that is the justification in the next slide. Next slide, please. The reason is that we were finding very large discrepancies in different surveys in the countries. Some countries like the DHS were reporting large prevalence of anemia, where others of the micronutrient surveys were lower than that. And the difference could be between 1.5 to 2.7 times. These are data from preschool age children. And that changes the category of the country from severe to moderate or moderate to mild anemia. This is really have large importance in public health. But if you can notice, the methodologies were different. Like Leila was describing, there are different factors that affect the results. In the DHSs is the use of drops of capillary blood and mostly HemoQ 201. In the micronutrient surveys, mostly was venous blood and the HemoQ 301. There is a series of different changes that we need to review. That is what the reason we started doing this work. May I have the next slide? Next slide, please. Leila already presented to us the definitions of accuracy and precision, and I will not repeat those things. And accuracy is really the certainty that we are estimating the true value. And if that is systematic, we can adjust our methods. Precision or the variability or the dispersion is something random that we cannot change. And it comes from the machine, the sample, and the skills of the operators. But another important type of factor is robustness, how the same method is going to perform in different hands. In the HIM work, we try to analyze the three main factors: accuracy, precision, and robustness. And I'm going to start explaining those. May I have the next one? Mexico, the Institute of Public Health was part of the HIM group, but they didn't receive a grant because they wanted to have the response fast, because they needed to use a reliable method into the National Nutrition Service. What they did is trying to characterize what happened with the different type of combinations of venous blood, pool of capillary blood, and drops of capillary blood using HemoQ-201. But before that, they were looking what is the reliability of a gold standard. And they use an hematology analyzer based on Drunkins. And they compare that hematology analyzer against another one. This figure shows to us the correlation between the two hematological analyzers, with samples coming from preschool children, women, and the elderly, in order to have a range of hemoglobin concentrations between 8 to 16. And you can see the reproducibility, the precision, the accuracy, and the robustness of the method was excellent. The coefficients of variation of these different samples, analyzing only once, was less than 2 grams per liter, was really precise results. The slope is 1 and the intercept is 0, which means that the two methods were equivalent. Now we have a gold standard how to compare the results that we can get from the HemoQs. The next slide, please. This figure that are going to see are the Bland-Allman data. Next slide, please. And with these three different types of blood coming from the same individuals, the venous blood, the pool of capillary blood at the center, and the drops of capillary blood. Like Leila was explaining, the average of the difference between the reading of the HemoQ and the gold standard is in the vertical axis, and is represented in the figures by a purple line. That is the average difference. That is the systematic error, or is the bias. In this case, the HemoQ-201 plus was having a positive bias of around 0.4 grams per deciliter, of around 4 grams per liter. The dispersion, or is the variation or the imprecision of the method, is shown in the figures by the red lines. And you can see in this figure to drops of capillary blood. And if you remember the 2 grams per liter that I showed before, and I explained for the hematological analyzer, in this case, that dispersion is not 2. It could be as large as 20. And that is the difference between an hematological analyzer and at this point of analysis using a HemoQ. May I have the next slide, please? With the bias, we can make an adjustment because it's a systematic bias. We can subtract the difference that we already in the bias to the different data, and we can adjust the values. Next slide, please. Next slide. Oh, no, one before. The previous slide. Okay, now it's the same graphs, but without the bias. You can see that logically we corrected the bias in the venous blood. We say we did the same in the pool capillary blood, but that was not possible to do in the drops of capillary blood. The conclusion of this study is that the preferable sample to measure hemoglobin concentration is venous blood. Although in the case of Mexico, even the pool of capillary blood can approximate the data from the venous blood with a slightly larger variation, but the results were still acceptable. But the drops of capillary blood were not correctable, and the accuracy and the imprecision were not acceptable. The next slide. Next slide, please. Are these findings new? Not at all. This figure comes from a paper that was published 25 years ago, and it shows exactly the findings that the Institute of Public Health of Mexico did, that every single circle here is the variation of a duplicate. The panel A and panel B are drops of capillary blood. These are results obtained by persons who have very good skills in the lab, by medical personnel. The panel C is the pool of capillary blood, and the panel D is venous blood. And you can see the variation in the duplicate. For the venous blood, at the bottom is around 5 grams per liter. The pool of capillary blood, 10 grams per liter. And when you use the drops of capillary blood, the variation in the duplicates could be as large as 20 to 30 grams per liter. This is the problem of the variation. And in this case, it says clearly that it's come from the sample. It's not coming from the machine, and it's not coming from the skills of the operators. May I have the next one, please? In the HIM work, we look for robustness. What is happening with these different variables in these 5 different countries? This we are showing the variation. That means it's the imprecision in Guatemala, in Cambodia, in Tanzania, in Lebanon, and Nigeria, using 3 different types of HemoQ, 201 plus, the 301, and the 801. And you can see very clearly, like the sample that needs to be used is venous blood. That is producing variation lower than 10 grams per liter. Once we move into the pool of the single drops of capillary blood, the error could be as large as 20 grams per liter. You remember when I was talking about the hematology analyzer, that the variation is between 2 to 3 grams per liter. In this case, we are accepting 10 grams per liter because we are really trying to use this equipment in the field. It cannot be used for research. This variation for research is too large. But in any case, we can live with that variation. But the important part also of this figure is telling us that the pool of capillary blood was not as good as we were thinking. But that depends in the country, which means depends in the operator. And the next step in this HIM study, we are trying to look what is the conditions that produces good samples of pool of capillary blood in order to approximate the results of venous blood. Next slide. In this figure, we are going to look at a different thing. This is the bias. This is the average of the differences. Look only the first 2 columns, only the venous blood. That is the comparison between the HemoQs and the gold standard. And if that difference is lower than 1 grams per liter, which would be very good, it's going to be green. Yellow is between 1 to 2, orange is between 2 to 4, and about 4 is the strong red. And as you can see, that are problems in all the machines. All the machines have some bias, but those could be correctable. And once we corrected that, the adjusted values are lower than 1 gram per liter. This is important because we usually don't do this in the field. In the lab, we always try to systematize or verify the performance of the machines, and we need to do that. The other thing from this figure is the 301 HemoQs were consistently doing a higher, larger systematic difference. But that does not mean that the machines cannot be used. They can be used if previously they are going to be verified and adjusted by the bias. But this is machine problem. The next one. Now let me move to the implication of these results. These are theoretically modeling, but these are very important because it can predict what is going to happen in the field. In this case, is the distribution of the hemoglobin concentration in a population, is the blue curve. In this case, we have a hemoglobin concentration of 120 grams per liter with a standard deviation of 10. but the bias of the equipment is around 4 grams per liter, which is the yellow curves. You move that figure to the right. Then you have a threshold value, and in the graph in the right is the cumulative figure for order to see and easier to understand. When the systematic bias is positive, in this case 4 grams per liter, but keeping the standard deviation the same, we are underestimating the anemia prevalence. The anemia prevalence was around 16, but now with a systematic bias of 4 grams per liter is reduced to 8. But the main problem is not the bias of the machine. The main problem is the diversity of the variation of the methodology, which is the red curve. Even when the machine could have a positive bias, the variation is larger. In this case, instead of 10 grams per liter or standard deviation, is 20. We are going to overestimate the prevalence of anemia from 16 to 24. And that is exactly what is happening in the comparisons of using finger pricking blood instead of venous blood in the field. Next slide, please. Next slide. May I have the next one, please?
Apologies, Omar. I think there's a delay. I have put in the next slide.
Okay.
Do you see it now?
Okay. Yeah, and this is here. Yes, I will wait then between slides. And in this case, it's a theoretical approximation, but it's to showing you what is the problem of the variation. Here, I accepting there are 5 quintiles of well groups, and in each well group, the concentration of hemoglobin is increasing from 110 to 120 grams per liter. If the standard deviation is 5 grams per liter in the methodology, the estimate prevalence of anemia using 110 grams per liter at the threshold is going from 50% to 2%. This is a method with a good resolution to identify the prevalence of anemia. But what happens if the method has a variation on a standard deviation of 20 grams per liter, which is usually what is happening in the actual use of the HemoQs in the field? Now the difference between among the groups is reduced. Now it's only from 50 to 31%. And if you see the proportions of the difference at the bottom of this table, you can see that the errors could be from 1 to 15 times. The difference is depending in which is the concentration of the hemoglobin, depending in the threshold. And that is in the under conservative figures, because the variation could be increased when the concentration of hemoglobin increase. And what we are looking in the data from the field. The next one is going to tell us the true results from Tanzania. May I have the next slide? Here are the data that is showing the anemia prevalence in 3 DHSs in Tanzania, years 2004, 2010, and 2015, in preschool age children and in women. And you can see it's exactly what was predicted by my calculations in the previous slide. It's very different. The difference among the groups is very small. And in some cases, even the wealthy groups have higher anemia prevalence than the previous group. And this is not possible. In the year 2010, it was a reduction of anemia prevalence. But I'm thinking that this is not a biological impact. This is something regarding the quality of the methodology, the quality of the machines that were used, the training, or something else. I mean, if we don't know what are the reasons of the factors that changes the values of hemoglobin in the field, we cannot really use the methodology to make comparisons among the years and among groups. May I have the next slide? This figure shows to us the situation in Guatemala. The red lines are showing us the prevalence estimated using drops of finger pricking blood, and the blue ones is using venous blood. And the red one is 201 plus, and the blue one is 301 plus. But which is clear, the country has very different scenarios using one type of methodology over the other. This is a mix between types of blood as well as types of machines. But in the year 2010, it was using venous blood and 201 plus. And that information was not published because the difference was so large that was a fear that it was not possible really to do the comparison. But we'll tell you that depending on the method, a country could predict prevalence of anemia from severe to mild. It's not a biological conclusion. It's a problem of the methodology. The next one. Now if we move to individual cases, why is so important to have accurate and precise methodologies? In this case, it's assuming that a child has a hemoglobin concentration of 115 grams per liter. Anemia in that child is predicted when the hemoglobin concentration is lower than 110. In the case of a hematological analyzer, which is the number 3 grams per liter variation, doesn't matter the variation. The kit is going to be very well classified. But when we increase the variation of the methodology, and we move to the right, and we have drops of capillary blood, and in a hemoq in any place, and the variation is larger than 20 grams per liter, that kit could be classified as anemic when it is not. But what is the worst case? An anemic kit could be classified as not anemic only because the variation in the results of the methodology. That is why it's so important to have accuracy and precision. And at the bottom of this figure, I have added something that we are trying to make in our studies. We are trying to adjust for percentiles of the variation in the hemoglobin concentration. And we are looking at discussing if we are used from 90 to 95 percentile or from 95 to 97 percentile. The difference between these two percentiles is only 2 grams per liter. We are also corrected by altitude, and every 500 meters is around 3 grams per liter. If we are making our accuracy in these calculations, we also need to do the same with our methodology. The accuracy of our method is much larger than these corrections that we are trying to do. The next slide. And this is for completing my talk. And this is a study with 6 individuals. And 6 individuals were sufficient to show what is in this picture. It's using hemoq. In the left panel is 5 different estimations of hemoglobin concentration using the hemoq with venous blood. You can see the precision of the machine that is very good and reproducible results. For the same individuals with finger prick drops of blood, you can see the variation in the right. It's completely different. The 6 is the average of all of them. That means all depends in the drop of blood. It is not possible really to have a reliable determination using drops of capillary blood. And finally, my conclusions. Clearly, the sample of choice for the determination of hemoglobin and therefore for the estimation of the anemia prevalence in populations and individuals is venous blood. Results of hemoglobin concentrations use drops of capillary blood are erroneous, even in the hands of experienced personnel. Pool of capillary blood may also be useful, but more work is needed as the precision of the results vary from country to country. The random error when using drops of capillary blood is neither correctable nor predictable, and therefore keeping the use of samples for following trends of anemia prevalence is fallacious. Moreover, each device must be verified before being used, as each one of them may have unacceptable bias. The systematic error might be corrected very easily through the analysis of a few samples of venous blood and comparing results versus those of an hematology analysis. This is something that we do usually in the lab and could be done in the field. Thank you too for your attention.
Wonderful. Thank you so much, Omar. And over to you, Sorrel.
Great. Good morning, afternoon, evening, everyone. It's a pleasure to be with you today to share the results of the hemoglobin pilot that DHS conducted and also discuss survey implications for measuring hemoglobin using venous blood. So the DHS program is the single largest source of hemoglobin data globally and has been using the same procedure since the 1990s, which is a single drop of capillary blood measured on a HemoQ 201 plus. In a few cases, another type of device was used. For reasons noted by previous presenters, DHS recently conducted a pilot to test differences in hemoglobin concentration depending on the source of blood. These and other results will be used to inform the DHS program's data collection procedures and improve data interpretation. Next slide. So there's still a delay or next, yeah, there we go. All right, so the design for the pilot is we carried it out in Uganda. It was in a controlled setting and in a field setting. And what we did is a single drop of capillary blood, pooled capillary blood, and venous blood were tested on a HemoQ 201 plus device. And these results were compared to the gold standard of venous blood on a hematology analyzer. In the controlled setting, all 3 blood sources were measured on the same individual. In the field setting, venous blood was collected from all participants, and participants were randomized to either a single drop of capillary blood or pooled capillary blood. Recruitment for the controlled setting was a convenient sample from nearby communities, and participants were brought to a clinic for testing. The field setting mimicked a typical DHS survey. It was actually nested within our overall DHS pilot. And recruitment for this was a convenient sample, and blood collection was done at the household after administering DHS questionnaires. Next slide. So essentially what I'm showing here is the types of comparisons that we made. So we assessed the agreement between paired hemoglobin concentration of the gold standard, as I said, venous blood on an autoanalyzer, against blood type measured on a HemoQ 201 plus analyzer. But we also assessed the agreement using the HemoQ 201 plus analyzer with venous as the gold standard on the HemoQ 201 plus against either pooled or single drop capillary blood also measured on the HemoQ 201 plus. The reason for this is doing these comparisons allowed for the evaluation of differences attributable to the analyzer, to the type of device that was used to analyze the samples, and also attributable to blood source. Next slide. Okay, so there's a lot, I'm going to dive into the results, and there's a lot going on in this slide, so I'm just going to walk you through what you're seeing. I am presenting results with the controlled and the field setting combined because our findings were similar across these 2 settings. Shown here are Bland-Altman plots, which helps us understand if there's bias between 2 measures of the same thing and whether that bias is dependent on the concentration. If the 2 measures agreed perfectly, the dots would be lined up horizontally on 0. The red lines indicate a 95% limit of agreement. The y-axis is the hemoglobin result by blood source measured on the HemoQ 201 plus minus the hematology analyzer. And the x-axis shows the average of these 2 measures. You've got children at the top, women at the bottom. Venous is all the way to the left, pooled is in the middle, and single drop is to the right. So what you can see here, moving from left to right, is the least amount of variability was found in venous blood, and the greatest amount of variability was found in single drop capillary. The limits of agreement for each blood source, which is a measure of variation, found in our pilot, fell about in the middle of what we've seen from other published studies. The average difference between the gold standard and each comparison was less than 0.5 grams per deciliter. So this is a bit less than the values presented in Leila's hypothetical situation earlier on the amount of bias associated with the blood source. Next slide. Sorry, I know there's a delay, but next slide. Okay. All right. So in the previous slide, the comparisons that you were looking at included differences due to the instrument used for measuring hemoglobin, which I'll refer to as analytical variation, as well as differences by sample type, which I'll refer to as pre-analytical variation. So here what we are showing are results from the HemoQ 201 plus only, because this removes the analytic variation. So we're now comparing pooled capillary blood and single drop capillary blood measured on the HemoQ 201 plus to venous blood measured on the HemoQ 201 plus. And we are seeing similar results to the previous slide in terms of both variation and the average differences in hemoglobin concentrations, which really means, at least in our study, this isn't an instrument issue, but a blood source issue. Next slide. So how does this impact anemia estimates? We had a large enough sample size to look at this. And so what I'm showing here is in blue is the gold standard of venous blood in the autoanalyzer. In red is venous blood on the 201 plus. In gold is the capillary pooled blood. And in green is the capillary single drop blood. Results from children are on the left and results from women are on the right. So what we found when comparing prevalence estimates between the gold standard and each blood source, the pooled blood was statistically significantly lower compared to the gold standard for both children and women. There were no statistically significant differences between the gold standard and venous blood on the HemoQ 201 plus or single drop capillary blood on the HemoQ 201 plus. The same pattern was seen when comparing venous blood measured on the HemoQ 201 plus machine to pooled and single drop capillary blood also measured on the HemoQ 201 plus machine. These results aren't shown, but the pattern was the same. Next slide. Okay. So in summary, we found venous blood measured on the HemoQ 201 plus analyzer had the highest performance and no difference in anemia estimates. So while pooled blood had less variability than the single drop capillary blood and really performed better than the single drop capillary blood, there were actually statistically significant differences in anemia estimates for both children and women. We think the reason we are seeing differences in pooled blood compared to venous blood, but not single drop, is because the variation went in both directions for single drop capillary blood, but for pooled blood, it was more unidirectional in our study. So overall, we found the average bias is small for what the error introduced by hemoglobin measurement, but on an individual sample level, we see pretty high variation for capillary, both single drop and pooled compared to venous blood. I think it's important to note that I have not made a conclusion on whether venous blood must be used over capillary blood. This is because there are no agreed upon acceptability criteria that have been established for population-based surveys on what is essentially good enough. So where is the DHS program going from here? At this time, we are continuing to use a single drop of capillary blood. As a next step, we're really looking forward to the results of additional external research, and we're hoping that an expert group like TEAM will come together and define what is considered to be an acceptable difference between a gold standard method and blood type for use in population-based surveys. Next slide. So the reason that DHS embarked on our pilot study was because a change from venous to capillary blood could have a major impact on data collection procedures. So next, I'm going to share some potential implications of using venous blood based on DHS staff's experience implementing surveys. So I'll start with the first 3 bullets, which are all at the preparation phase for the survey. So surveys that are implemented by a country's statistical office, which is what DHS typically does, usually have limited experience with venous blood collection, and there may be hesitancy to include it in their surveys. Country buy-in for using venous blood may be less of an issue when the survey is implemented through a Ministry of Health. In terms of recruitment of staff, because of the scale of these surveys, a very large number of certified phlebotomists is required to collect venous blood. And there really is a bigger pool of technicians to draw from for capillary blood because this can be taught during the training. At the training phase, typically less training on the blood collection technique is required for certified phlebotomists because they've already been certified for collecting venous blood, compared to technicians collecting capillary blood who have to often be taught how to do it. Although in DHS surveys, we sometimes use the same data collectors from survey to survey. So what is a challenge is that phlebotomists often don't have extensive experience with venous blood collection in very young children, and we collect hemoglobin on children 6 to 59 months. And it can be challenging to find children for phlebotomists to practice on, and this can potentially require, going to more clinic visits and extending the training time. So the next 3 bullets are at the data collection phase. So on invasiveness, so from a perception standpoint, venous blood is seen as more invasive by respondents. They also tend to think it will be more painful than capillary blood collection, and often have kind of concerns, particularly with young children having this procedure done. Although in reality, actually taking a capillary prick can be more painful than taking a venous blood draw. But from a perception standpoint, which can impact response rates, that needs to be taken into consideration. So where I have the kind of greatest concern about using venous blood compared to capillary blood is the potential that response rates may be lower in some countries when using venous blood. So what I'm showing in this table here is just a convenient sample of 14 surveys that included micronutrients. And I'm showing the average response rate was 81% for children and 88% for women. But the range of response rates was from 50% to nearly 100%. Looking at other types of surveys, response rates were a little higher, showing at 92% for children, 90% for women, and 91% for men. But as a comparison in malaria indicator surveys, which is a type of survey under the DHS program, the average response rates for hemoglobin measurement on capillary blood is really high at 93% average and ranging from 71 to nearly 100% in children. Sex selection bias could occur when measuring venous blood if there are higher refusal rates in urban areas, or based on age, or if their parents on behalf of sick children may not want to have venous blood done, and potentially increased failure rate of venous puncture for sick individuals. Okay, so moving on to the data interpretation phase and also kind of envisioning the future. So most surveys to date have used capillary blood to measure hemoglobin. So if there is a shift to venous blood, this will likely impact the ability to monitor long-term trends. In terms of the impact on other biomarkers, as Leila mentioned, venous blood would allow for the potential of doing more biomarkers. However, this is only possible in a survey context if extensive logistics are added to allow for lab-based testing. And increasing the number of biomarkers can affect the quality of the other components of a survey, particularly if it's a multi-topic survey that has, many moving pieces. In terms of cost, supply costs may increase using venous blood, but supply costs really aren't the greatest expense. The highest expense is paying field workers time, because at least for multi-topic surveys, it can take around 6 months to collect the data. So it's possible that phlebotomist salaries may be higher than those who'd measured capillary blood. And this may also have unintended consequences of kind of resentment within the survey data collection team if phlebotomist salaries are higher than other team members. It also takes a little bit longer to measure venous blood than it does to measure capillary blood, and this potentially may require more time in the field. So all of that is to say, DHS is keenly kind of tracking the data that's coming out, the global bodies that are looking to make recommendations on the blood source for hemoglobin collection. And what I can't tell you is what DHS is going to do in terms of whether hemoglobin would remain a standard biomarker if there was a switch to venous blood, because that's really a decision that would be made by the project in partnership with USAID once recommendations have come out. However, even if it remains a standard, countries, as always, will have the option to exclude hemoglobin, even if it is a standard part of the survey, if they don't want to include it in their survey. Right now, pretty much all countries are including hemoglobin within their surveys. So we really look forward to seeing what happens and what team does. And I just want to thank you for listening today.
Thank you very much, Sorrel. And over to you, Sara, to maybe wrap it up with what the team will be producing. Thank you.
Thanks. If you go to the next slide. Just to let you know, the technical note 1 will be basically addressing much of what Dr. Larson presented at the beginning with a little bit of additional information. Because this has to go through a stepwise approval with WHO UNICEF, because the team group is a WHO UNICEF working group, we anticipate that first technical note will be coming out sometime this summer. And technical note 2, and I noted that there were some who were interested in things like, what's happening? Is there some kind of adjustment that we need to do? And the technical note 2 will be addressing more of the research that Dr. Dary and then also what Sorrel Namaste discussed with the DHS data, the research that we have that are still coming out. So that technical note will be to address a little bit more about, so what is the research showing us? What is best practice? Can we now make a judgment or a solid recommendation on what should be the best practice? Do we have enough data to now recommend that we no longer use venous or capillary blood for hemoglobin assessment, or are there ways that we can collect using pooled capillary blood that would be accurate enough to ensure that we're not mislabeling anemia overall in the countries where we're working. We anticipate that that technical note, because of the research that is still coming out, will be coming about the end of this year. And then if we find that there are other technical notes, some of the topics that questions that came up, we would consider for technical notes as well. And with that, I think I will turn it back for more general questions to the group.
Great, thank you. Chica, can I take over for the question and answer?
Yes, definitely.
Great. Thank you all the presenters for your very rich presentations, and Sarah for the updates on the technical working group and the technical notes. I'm just looking at all the questions. Yes, Leila, please turn on your camera too. I have a list of some of the questions, and no one's got their hands up right now. So let me go over. Let me start with Leila. Can you give us a little bit of a more in-depth overview about the sources of blood for the hemoglobin assessment? And by that I mean, you know, for example, how the number of drops are taken in the drops of capillary blood versus how we make the finger prick for the pooled blood sample versus the venous blood sample. Over.
Sorry, so you're asking me to give an overview of what the measurement of hemoglobin is like?
A greater description of the blood collection techniques and what that involves.
Okay, sure. Okay, so let me start with venous. So the venous, and I guess hopefully the slides will be shared with everybody, because there are some key characteristics for each that I listed in the tables. And that is from the technical note, which is coming out soon, as Dr. Wuehler was saying. So for venous blood, it's about, the venous sample is usually from a vein, from the arm. Like Sorrel was saying, it usually takes a bit more time. It requires a phlebotomist. Then to measure hemoglobin, it then requires sort of a transport chain to wherever there is electricity to then have to get the measurement for the hemoglobin. It's usually done on a hematology analyzer. However, venous blood can also be used to measure hemoglobin on a HemaQ in the field as well. But as we're seeing, the HemaQ device, there are some variations by the analytic method used as well. So that's for venous. For capillary, there's two main types. So there's a single drop and there's the pooled sample. The single drop is sort of a prick on the finger. I said you could do the earlobe or the heel as well. But on the finger, it would be wiping away the first and the second drop, and then using a micro cuvette to take the third drop and measure hemoglobin on a HemaQ or a portable hemoglobinometer that way. For the pooled samples, it requires multiple drops, and then the same method of using a micro cuvette, taking a sample and measuring it on a portable hemoglobinometer. Hopefully that gives a quick description. Are there any more specific questions?
I'm just thinking that the pooled blood sample requires a deeper finger stick and might be more painful than the normal the click finger stick method for the blood drops. So that's another factor that needs to be brought into consideration when we're deciding what types of tools. Yeah.
Thank you.
Good. Excellent. So then there were questions. Adama and others had some questions on adjustments and how adjustments were done for the differences that come from the tool used for the measurement of hemoglobin concentration. So yes, can I ask Omar to come in on this point?
Yeah, thank you for the question. Whoever asked that. You can correct systematic errors. I mean, the bias of the instrument. You cannot correct random error, which means that the dispersion or the variation of the method is there and we cannot correct. That's what I'm saying that trying to look trends, continue using finger pricking blood is not go. We don't know the past. What are the conditions of all these surveys were done? And taking advantage of this, looking the data that Sorrel presented regarding the study in Uganda, that confirms the work done in Mexico as well as the work done by the HIM group. The finger pricking drops has too large variation. In the case of Uganda, was between 25 to 30 grams per liter. That is completely unacceptable. And that was in this study. And even the venous blood in the HemoQ, the variation was between 15 to 16 grams per liter, well above all the other studies, which means that it's not only the quality of the drop which making the introduction of the data, it's also how the machine is being used and how the samples are being taken. But even in good hands, the drops of capillary blood are not working. And I think we have sufficient evidence to say so. Now, when we compare the prevalences using the Uganda data, and you can see the variation of the estimation was plus minus 10% anemia in kids and plus minus 5% anemia in women. That is not possible. I mean, it only reveals that really the problem is the variation of the method. And we need to work not only in the verification of the equipment, we need to work in how the people is using the machines. They need to use venous blood, and even in that case, they cannot have variation larger than 10 grams per liter. I think we have a lot of things to do, and this is very important because this is one of the goals or the targets of nutrition for the world, how to reduce anemia prevalence in women by 50%. And we have not seen that. And one of the reasons is the use of not precise methodologies, and we need to improve this. This is the answer, Robert.
Great. Any other presenters want to come in on this point?
I'll just add just a quick, I want to emphasize that the issue is, as Dr. Dary was saying, the issue is with the imprecision. So the spread of the data points that we're seeing with single drop capillary samples. I think coming up with an adjustment factor, that would be lovely. That would make things a lot easier, but I don't think we're quite there yet. I think that the bias that we're seeing can vary quite a bit by the survey, can vary by the population, so children versus non-pregnant women versus pregnant women. So I don't think we're quite there yet. And as Dr. Namaste was saying, we don't have the sort of criteria yet to say what is acceptable and what's not acceptable. Thank you.
Mm-hmm. Any other inputs on this point? If not, I would like to ask from the audience, are there any questions that anyone would like to ask? And please raise your hand and we can call on you. If yes, Bo Peterson, please go ahead. Let me turn on your mic. Yes, is it on?
It appears to be on. I hope you can hear me.
Yes, we can hear you.
No, because I noticed that there were no more questions. I have a really simple question, because I think to some there is a bit confusion about what the problem is. So I just want to clarify that there is no problem with the machinery, but we have a problem with the blood, to put it plainly. Is that correct?
Mm-hmm. Leila, you're the only one with your camera on, so please go ahead.
Am I the only one? Okay. I think we're all like, oh. That's a difficult question. I would say, and I see that Dr. Dary has his hand up, which is good. I would say the imprecision that we're seeing. So the problem is the imprecision. So the imprecision that we're seeing from analytic devices is much less than what we're seeing from blood source. So the differences that we're seeing from capillary versus venous are much larger and more worrying than the differences that we're seeing on average from the analytic devices used. So that's what I would say with that. I personally, I would say that if you have well-trained people using portable hemoglobinometer, a HemoQ, that should be, and that your device is calibrated and et cetera, that should be just fine to use. Yeah. The issue is with the single drop capillary samples.
Dr. Dary, please come in.
Yeah, I would like to complement what Leila just said. The machines have very reproducible results. And we have seen machines that work months after months and produce the same results. And any bias could be small, especially in the 201 plus. It's less than 2 grams per liter, which means that this is something that we need to decide. If any imprecision, or in this case, any inaccuracy lower than that, probably do not require a big change. I mean, it's something like, but you need to verify machine per machine because it does depend in the model, depends in the machine. But that is easy to do. One, we verify the using venous blood in the HemoQs and in hematological analyzers. If there is any bias, small or not so small, like 4 grams per liter, we can correct that. I mean, it's something that could be done. The machines are very reproducible. The dispersion of the single drops is the problem, but also how to use the machines. I mean, that is also what we need to train the people in order for them to really look the use of the machines in the best way, because the machines itself are good machines. This is the problem of the operator and the problem of the quality of the sample.
Great. We just had a question from Chesaluta about the change from capillary blood in Mexico, from capillary blood to venous blood, supposedly. And yeah, Dr. Dary, do you have any information on the implications of this change and any lessons learned?
Yeah, I think that in the call is Vanessa de la Cruz Góngora, who was the main author of this. I'm going to respond for her, but if I make any things are incorrect or she would like to comment, I would like to ask her to do it. What my colleagues in Mexico have telling me is that when they switch to venous blood, now it's rare to find anemia in the country. And this is a huge change. But Mexico is a middle income country, which means already anemia was sufficiently low, but they will still have some. But when they look a good method, even that small prevalence was reduced to almost negligible to make attention in certain groups. This is what is going to happen. And if we do this in all the world, the anemia prevalence that we have seen is going to reduce very easily by half. That does not mean that there is not anemia, but if we have a method with a better resolution, we are going to identify the population group that really needs attention to those population groups that are already fine. I think this is for the targeted of the interventions, but it's also for following the evolution of our success in the interventions. So far, because this method, it has so large variation, we have not seen that. I think that is really important for programs and for epidemiological studies to move to a more accurate and precise methodology.
Good. Other participants, would you like to come in on that point? Okay, and Chesa did follow up with asking about the compliance of the participants to the change to Vanessa de la Cruz, would you like to come in and speak on this? I saw you just for a second. If you could raise your hand if you'd like to speak. Yep. Okay. Yes, please. You are unmuted. Please go ahead. Can you? You are unmuted if you'd like to talk.
Okay, thank you.
Yes.
Thank you for the opportunity. I agree with the Dr. Dary comments. He's correct. We're discussing the trend of anemia in Mexico. It's not that explain the increasing trend of anemia in comparison with the declining trend in iron deficiency. And when we moved to venous blood, we found a really low prevalence of anemia in the Mexican population now. There is no other reason or causal factor that can explain before the COVID pandemic. There is no other causal factor that could be explaining this increasing trend. And now, after the COVID pandemic, it seems that we don't have that problem anymore. So yeah, we move to measure anemia using venous blood because we have social programs that are targeted and designated to vulnerable population to address micronutrient deficiency and anemia. And because of that, we need to measure very well how anemia is affecting and where is the problem of anemia in our region. Thank you.
Great. Thank you for those inputs. Much appreciated. Are there any other questions from the group? Manoj, you had a question. Please let me unmute you. Please go ahead. Manoj Raut. Manoj, please go ahead if you'd like to ask a question.
Thank you, Robert. Yeah, thank you very much for the nice presentations. Actually, I had one query regarding that. Like we know that venous blood is more precise and the accuracy is better than the capillary blood samples, but certain like DHS, most of the countries DHS is using capillary blood sample. And when if you shift to venous blood sampling, if there is a change in the anemia, like it's seen in national nutrition surveys, difference is there, it is lower than the estimate of DHS. But how do we compare the trends? Like, because the methodology will be totally different, and whether there is actual reduction in anemia, or how do we measure that change if we are changing the methodology from capillary to venous going forward? Yeah, thank you. Thank you for the nice presentation.
Mm-hmm. Great, thank you for the question. Yes, over to the presenters for that. That is one of the quandaries that we're struggling to face right now. Sara, would you like to start a comment on that?
I thought that Omar's had his hand up.
Okay. Omar, is your hand up for this question?
Yeah, that's correct. In the slide that I presented regarding Guatemala, this is not possible to combine the two results. I mean, that's a conclusion. Those are very different. But on the other hand, continue trying to have confidence in the data from the past using finger pricking blood is also incorrect, because we don't know how's the quality in the past, and it could be changing year after year and teams and other things, which means that the sad conclusion of this is that most countries do not know what is the actual anemia prevalence of their own population, because we have depending in the finger pricking. And we need to accept that. I mean, we need to accept that and start measuring the things right. To think that we can look any trends in using finger pricked blood is fallacious, as one my conclusion. It's not possible. That means the error is so large that it's not letting us really to look anything about that. And that is what we need to accept. And this is the reality of our actual situation.
And any other presenters want to comment on that point?
I think that
Okay.
Maria Nieves would probably respond to that.
Yes. Maria, you are unmuted. Please come in on this point. Maria Nieves.
Can you hear me now?
Yes, we can hear you.
Okay. Thank you. Thank you very much, and thank you for the nice and informative presentation. Has been a very nice meeting. But I with this last question and with the comment from Omar, I was wondering what I understand that this is not comparable. If we're moving to Venus and we need new estimates, new data, and things like that. But what is also true is probably that if we are underestimating, we are still hanging there with the problem of moderate and severe anemia, probably. We will move that it will go down from the prevalence of anemia based basically on what we are saying that is mild anemia right now, right? And that makes me wonder, what are we going to do with that information? How are we going to convince countries or governments that this is still a real important problem and we need to do things about that? That's it. Thank you.
Yes, no, those are key points. Any presenters want to comment on? And if not, can we have our last question from Luis Mejia? Please go ahead. Your mic is unmuted. Please go ahead. Luis, can you hear it? Please go ahead if you would like to ask a question. If Luis can come in, please, Vanessa de la Cruz, you are unmuted. Vanessa, please go ahead.
I don't have any comment.
Have a question or a point to ask.
No, I don't have any comment. Sorry, I don't know why.
Okay, sorry. Yeah. Okay.
Can you hear me now?
Yes, Luis, we can hear you. Please go ahead.
Okay, thank you. Good morning. The question I have is a practical question. If one wants to go for venous blood, what are the implications for collecting the blood from small children? Taking blood from small children, venous blood, is not easy. It's not very practical. I mean, I think that could be a drawback. In other words, how, up to what point in age can you do it in more or less an easy way? So can you address that point? Taking blood sample, venous blood sample from small children, that, as we know, is kind of the highest risk for anemia. Thank you.
Good. Yes. Omar, would you like to respond to this question?
Yes, I saw also that Reynel Mazariegos from Inca, Guatemala, is in the as an attendant, and she could answer that.
Mm-hmm.
That's a difficult thing, but an experienced phlebotomist could do it. I mean, the countries have experience to do that. But then the problem is, this is a difficult sample to take, but this is the only sample that we're going to provide you reliable results. If we continue, especially in the kids, finger pricking blood is giving completely different an incorrect answer. I mean, we cannot continue using that only because that's the sample that we can take, because the results are incorrect. And I always said, it's better not to have results that have erroneous results, because that will bring us to incorrect interventions. That's talking about that part. But in the case of the kids, this is another issue. And this is the threshold that we are using to diagnose anemia. And this is a problem that also the team group is going to start analyzing. At this time, WHO has only one threshold for kids from 6 to 59 months. It's 11 grams per deciliter. And this is a big difference between the hemoglobin concentration, which is metabolically normal, between 6 to 24, which is much lower than 11. And if we correct that threshold, most of the anemias that we are seeing now in the kids probably is going to be reduced too. But that is a problem of the criteria. But regarding the sample of the blood, Dorinescu added, at one point for Maria Nieves Garcia, how can we now advocate for attention to anemia if we are introducing this noise in these things? We need to think in that. This is a very delicate point, how to transfer this information to the countries, because anemia is going to be there. What we are doing is that we are going to identify which communities are affected by anemia to those that not, and which is the impact of our interventions. That is the different thing that we need really to look at it. Thank you for the attention.
And Dora Ines, would you like to come in on some of these points and add your expertise? You should be unmuted. Dora, I saw your hand up, and you are unmuted if you would like to come in on these points. Please go ahead. We're having some problems with her microphone. You're unmuted on my side. Please go ahead and try. If otherwise, or we could take your comments in the chat. But we've come to the end. Thank you for all for the fantastic questions and answers. We have come to the end of our time for our webinar. And thank you for all the participation from the audience and the great presentations from our presenters and the very solid coordination from Archana and Chika. So at this point, I'd like to hand over to Archana to close the webinar. Over.
Thank you so much, Robert. I would like to extend my thanks to all the presenters, as well as the participants, for a very excellent webinar. I just wanted to remind people that the presentations and recordings will be available on the UNICEF SharePoint site for our internal UNICEF colleagues, but the recording will also be available externally on the Mix YouTube channel. So just give us a few hours to put that up, and we hope you'll be able to access those. I thought there was a question about getting those presentations, so that's where they will be, including all the references that the presenters had provided. Also a reminder that our next webinar will be in 2 weeks, April 5th. The topic is Global Progress on Tracking Populations in Slums and Informal Settlements, Key Lessons and Data Challenges. It will be presented by Robert Ndugba from UN Habitat. So until then, I wish you all a very nice day. Thank you so much.
Bye, everyone.
Bye, thank you.
Bye-bye, everyone. Thank you. Bye-bye.